Thank you so much for having us. Really appreciate it. My name is Rolando Mia, and I am with Zyris. And really appreciate you all giving us an opportunity to join and spend time with you. The purpose of this session is to basically cover aspects and basically deal with addressing dental aerosols in space. So rather than me sit here and spend a whole bunch of time talking about how great we are, what we'd like to do is share with you real live experiences with and real feedback. So joining me is Michelle Strange. Michelle is someone who knew it dear to our hearts. She's been a huge advocate for dental aerosols. She's been for many, many years screaming at the top of mountaintops about the importance of this. And you know what? Not a lot of people were listening, really. Not that they were being mean, but now that with the advent of COVID and all the issues that we're facing regarding aerosols, it's virtually everything that she's spoken about has come to that. So what I'd like to do is I'd like to hand it to her, and what we're going to go back and forth between this, hopefully provide you with some information that you can use to make good decisions. So, hey, Michelle.
Hi, good morning. Good morning to everyone. I'm so excited that I was even invited to be a part of this Ask the Expert session. I am very appreciative of OSAP and everyone that's taking the time to listen this morning. And, I thank you for that introduction, but, I definitely was piggybacking off of a lot of the research that I was reading and learning from amazing people that are probably on here watching, listening, and also have been speaking here during this OSAP conference. So I just want to say thank you to them for giving me a foundation to jump off of, because I have been fussing about aerosols. I always joke that I'm the squeaky wheel in dentistry sometimes, but I will fully admit that as a hygienist, so I've been a hygienist now for 16 years, in the dental industry for 20, and I have done it all wrong. I was a huge fan of aerosol generating procedures. All of my patients got ProfiJet at the time, Cavitron to every single patient, hand scaled. I did not wear the right mask. I did not use high volume evacuation. I probably didn't even change my mask for every patient for the first part of my career. And then, this is completely anecdotal, but my experience was I was always sick. I always had a respiratory infection. I actually had some patients that would joke, because one time I would have laryngitis when they'd come back for their 6 months, and they're like, oh, darn, you can talk now. You can't tell me about my cleaning between my teeth. And so when I really embraced guided biofilm management with using like glycine and erythritol, and started to come to these courses and started to learn about, I've learned about bloodborne pathogens, the start of my career, but aerosols and our aerosol standards were something that I was like thinking about. And when I started learning about it, I was like, I got to make a change. Like, if I'm going to be out there teaching and lecturing, and I'm a teacher in a school, I got to really up my game as a clinician. And so that's when I started to do some of my own practicing with different devices out there. And that's when I stumbled upon Isolite and Isovac and started developing my relationship with you guys over at Zyris. So I promise, you invited me on here, but it was a very organic invite because I am a big fan.
Awesome. Well, hey, thank you for that. It's interesting. Aerosols have become one of the biggest issues right now, and part of it has to do with a lack of general or definitive or empirical information regarding what's going on, what the effect of that is. Rather than focus on what we don't know, I'd like to take a minute to just explain what we've found or what we've done. So we've been asked, if you look at the way our system is designed, and in the research and in the discussion forums that we've seen, high-speed evacuation has been said is the key to minimizing, if not potentially eliminating, the majority of the aerosols in the air. So we've spent quite a bit of time doing that. We wanted to validate for ourselves how effective our system was, because we were getting a lot of feedback from clinicians indicating that. I mean, even Michelle had mentioned during the course, way before COVID and all, her experiences with it. So what I'd like to do is share with you an experiment that we did, because we were trying to validate and visualize what's going on. This only takes a couple seconds.
Yeah.
So high-speed evacuation, when you look at the context of what we're hearing from the WHO, WHO, all that type of stuff, is important. Hands-free is even more, and continuous. So what we did was we wanted to visualize or do some kind of visualization. So I'm going to share my screen here and
Great.
show you something that what we'd done before, and hopefully you all can see this. We wanted to do an experiment to understand the effect of this. So what we did was we put patient in the chair, and Dr. Hirsch started doing some work just to get a sense. And what we discovered is simply breathing, patients are ejecting quite a bit of that. Now, we recognize that a lot of that water is the spray coming from the actual handpiece. So we recognize that, but we also saw how it was being ejected out of the mouth. What we then did was we took the same procedure and we added the HVE. And what we noticed is there's quite a bit less of it escaping from the mouth. So this helped validate for us, okay, that's pretty cool. It does work. We then took the Isolite and we put that in because we wanted to see how effective, or if there was an effect of that system in evacuating and eliminating those aerosols. And we were happy to see that that didn't happen. Now, we've been talking to literally hundreds of clinicians out there. And what we've discovered is it's not about a silver bullet. In other words, there isn't just one thing that clinicians are using, that dental practice professionals are using to eliminate that. There are actually several. And one of them is adding an HVE to that Isolite. So we went ahead and did the exact same thing. And what we wanted to see was how effective that would be. So with Isolite and the HVE, what we found was virtually nothing, absolutely nothing, seemed to be escaping from the mouth. So the context here is it's not about just a single thing, it's about multiple things. PPE is important, filters are important, that type of stuff. So this is what we shared, and I'd love to hear from you, Michelle, about kind of your ideas around that, and then these additional or layering things to help in eliminating that.
Well, you know, and I appreciate the videos, and that's definitely coming from the perspective of the dentist and the having an assistant. And I definitely have the perspective of solo clinician as a hygienist. I have not been able to have a hygiene assistant. You unicorn hygienists out there have a hygiene assistant. I'm super envious of you all. So I do have a video of me practicing with it that I would love to share with you. One thing that I as a clinician am very honest and very frank about in the world of HVE tips is that there is not the holy grail. You definitely mentioned there's no silver bullet. And there's just a lot of things that I would suggest to my fellow clinicians out there right now, and that there's going to be a lot of variables. And I'm at number 15, I think, of tips that I have tried or devices that I have tried in the HVE world. Combinations, I found very similar to what you were showing there, that a combination of the Isolite or IsoVac, whatever it is that you're using, and a second high volume evacuation tip is what makes me the most successful. But it also depends on the room that I'm in, and if my patient's tolerant of it. It depends on the procedures that I'm doing. It depends on how much time. I mean, there's just so many variables. So for that reason, I just want everyone to know that there's just not going to take one device. But I would love to show you what I have been doing with the Isolite and IsoVac if I can. So I'm going to share my screen as well. So I start here. Hopefully you can see that. Can you see that on the screen now? Excellent. So I'm going to go ahead and start this video. And what I'm doing here, I am very lucky that I have 2 high volume evacuation suction tips on my device. That is not what everybody has. So in this video, I'm doing Isolite. And what I like about Isolite is that, and this is why I'm with you, Rolando. I don't know all the words, but there's a device that allows me to put a second tube, and I'll let you talk about what that is and what that means, so that I can have that second one. And here you can see I'm doing half mouth, so I've had to change how I flow through my appointments. You know, and that was a difficult thing. You know, I didn't enjoy it at first, but I grew to get into a new rhythm and a new routine with my patients. So I attack half a mouth, and whereas before I was doing like all the away surfaces, all the toward surfaces, and now I had to adjust that. I often add that second high volume evacuation, as you can see here, when I hit the anterior teeth. And especially when I'm adding, so I'm a big airflow user, but if this is any air powder procedures that you might be doing, or any time your ultrasonic is turned up a little bit higher and you're really getting a spray from it. In this particular video, I'm trying out a new bib. I know it looks strange, but I'm trying out a new bib that covers everything on the patient, but I'm using Isovac. And that's different because Isovac is portable. So when I am not in my room and I get kicked out of the room that has the Isolite, I can take that Isovac and actually put it into a different operatory. And it's also super cleansable from an infection control standpoint. I can pull it all apart, clean all the inside of it, which is fantastic. But I often am using, especially when I don't need a mirror, a second high volume evacuation. And, you know, I've tested a lot of those tips as well. This one is one with a flange that I really appreciate, especially when I get to those anterior areas. But this is just kind of the technique that I wanted to show everyone. I am often using it to two devices at all times, because I can't manage as a solo clinician to get the spatter spray aerosols that are coming from the device and not drowning my patient. I wish I had another arm sometimes, but these are my battles. Either the patient's drowning or I'm soaking them down, soaking me down. Aerosols are going everywhere. And so I do find the Isovac and Isolite really helpful because it is hands-free. And one of the things that I mentioned to somebody, and I was like, oh, I should probably bring this up to more people, is that I gravitate towards the hands-free option in the afternoons when I'm worn out. You know, when I'm worn out from that day of treating patients and you know, handling cords and my shoulders giving me a hard time and whatever that looks like for you. So I just wanted to share this with you. You can see where, again, I really use that second high volume evacuation, but I'll go ahead and stop that screen unless you have any thoughts or questions that you would like me to touch on.
Appreciate that, Michelle. There's quite a few, there are a whole bunch of questions that are coming through, and we'd love to spend the time to answer that. But what I would like to touch on is the systems briefly here, and then also address some of the things that we've been looking at. First of all, when I touched on the aerosols earlier, one of the comments was, that's a lot of spray, spatter, splatter. It works phenomenal for that. And there are aerosols that go as low as 50 microns that you physically can't see. I just wanted to clarify that was more to visualize, because we wanted to see whether or not it was actually sucking it in. Logic is those larger particles, if it was effective in sucking those in, it's probably as effective with some of the smaller ones. Plus, it's creating a negative vacuum space inside the mouth, which is an important context. So, if I could have the screen, I'm seeing Michelle. I don't know if you all are seeing me, because I wanted to show something here.
Yeah, I can see you.
Can you see me? Can everyone see me? Okay. Mm-hmm. One of the questions that's asked had to do with the Isolite and the system. There are two components to the Isolite. There are the actual devices that plug into the chair, and they're connected directly to the HVE. And then there are the mouthpieces. These mouthpieces are one-time use only. They're made out of a polymer, no silicone. And when you look at the way they're designed, there's an integrated bite block, a tongue guard, and a cheek guard. And one of the questions had to do with patients who are gagging. As a matter of fact, feedback we received is the patients who are gagging actually like this, because in the videos that you saw with Michelle, what you're seeing is when this is placed inside the mouth, you're not having to retract the tongue. Fluid isn't going down the throat. It's nicely obturated, and things are protected. The other thing about it is infection control, and this is something that Michelle has spoken to over and over and again. Because this is one-time use, it's discarded. And because it also evacuates through the bite block down here, the patient can actually control the amount of fluid inside. So it gives the patient kind of a way to relax. And I'll be honest, we've been told by numerous hygienists, and Michelle, you could validate this, when it's placed in the mouth, the patient can't talk. So,
so true.
You know, clinicians are able to get into the procedures nicely. When you work with each of the different control heads, it is right up against the cheek. These are changed out after every patient. And the way these are designed, they're designed to be opened and clean so that when a clinician is using it after each use, they replace this with another one, because these are, they're validated, they go into the autoclave, they're clean and sterilized, and then you're replacing these after every patient, and you're also discarding the mouthpiece. The final thing is there are 6 different sizes of these mouthpieces, and they range in size. There's a technique for placing them. You size it using a finger method, and once you get kind of the hang of it, it's easy, because the different sizes are designed to fit the anatomy and the morphology inside the mouth. So anything from pediatric doctors absolutely love it, because it gives them the ability to work by themselves and gives them a lot of room to do it, as well as, all the way up to adults if you're sedating patients. Hygienists, very recently, Michelle touched on it. I'm going to hand it back to her about it. Got to be honest with you, because of the way this is placed inside the mouth and that bite block, a couple of wonderful things. Patient's mouth stays open, things are nicely obturated. The issue, though, is it's going to kind of force you to change kind of the habits that you have inside the mouth, and that's an important context to have. So I don't know. The final thing is, on the Isolite 3, there's an actual component that enables you to add, it's called a power vacuum base, that enables you to add another hose or another HVE line so that you never lose your second HVE.
Right.
Did I answer your questions, Michelle?
Yes, and I actually see some coming in that I really am super excited about, because I wanted to talk about some of these topics. One of the gaggers that people are talking about, I haven't had any real issues, but if I do have, and I have had a few patients that couldn't tolerate it. For me as a clinician, that's a red flag or a big buzzer. Something's happening in my little head, and I'm going to reassess. I'm going to look for tongue ties. I'm going to check their airway. I'm going to have a conversation about sleep apnea. So if they can't tolerate the Isolite, it's triggering me to ask some additional questions and have a bigger conversation, to be very frank. And jaw fatigue. Actually, that's one of the things that I hear at first. Everyone's like, whoa, what you putting in my mouth? Like, that seems like a lot, Michelle. Like, let's talk about this. But once they get it in there and they start getting really comfortable and they can rest and relax on it, yeah, it's amazing. And I will second that they can't talk, and which is fantastic, because we're all hustling to get things done these days. We're fitting more and more into our appointments. So it's nice that they, and also, how many times have you been like, open? Nope, still open. Nope, we're still doing it. You gotta stay open. And they keep kind of like slowly closing down. Well, you don't have that issue. So it does make the appointment go by a little bit faster. The cost point, I will just say like I said, there's not a holy grail, but when I am trying to combat pulling in the back of the throat and aerosols, I'm almost always having to use 2 devices. And because there is a concern with backflow with LVE and high volume and low volume going at the same time, I'm always having a backflow preventer on there, or I'm having that second high volume. So there's a lot of tips and a lot of parts and pieces. So I just want to throw that out there too. I'm personally trying to keep track of all the parts and pieces that I use and what that cost looks like compared to when I use it on another procedure, and track that in addition to what works for me as a clinician and what works for my patients. And then the fulcrum. The one great thing about what Zyris did for me when I got my first device was that you had a one-on-one conversation with me, and you said you're going to have to change your fulcrum and your technique just a little bit. And I really appreciated that because when it happened and I had to I was fumbling and it was awkward. I think if I hadn't had that in the back of my head, I would have been like, this isn't going to work. This just isn't going to work. But I had that little person in the back of my head going, you're just going to have to adjust. You're going to have to change. And you do. And you get used to it. I did mention in this that I had to change my routine. We're all creatures of habit. So I was very used to hitting bam, 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 and then having the head turn over and hitting the other sides. That changed for me. So just know that going ahead. And you might occasionally just have to take it out and hit that spot and put it right back in. Or hit all the other spots and then come back, take it out and come back to that spot. Maybe it's like the distal of 32. I don't know, it depends on what that patient's working with. So I appreciate all those comments and those questions because they're very important questions, but I think just knowing also the training that goes with this. A lot of my fellow colleagues have been getting these devices purchased for them, not just Isolite, but a lot of different devices. And they get it in their operatory and they're like, this is not going to work for me. Like maybe their op is weird not weird. It's different than what some of us are using. Maybe they don't have the right training and they were like me 20 years into it, learning how to use a high volume evacuation. As a solo practitioner, I'm going to tell you right now, please show some grace to your team and yourself as you are learning how to navigate the new high volume evacuation tips. It's not easy. So make sure your team has the training, that you have the time to be trained, and have an open mind. And if you find that it's not working, you just pivot and you find something else that might work for you.
That's so cool. Thanks for that. There are a whole bunch of questions here, and we want to be mindful and respectful of the amount of time that everybody has. Really appreciate the time that you have. On the Zyris website, there's quite a bit of here. I want to hit a couple things that have been asked. First of all, somebody asked about the finger method. The key to using these mouthpieces is measuring the interincisal opening of the patient. So 1 finger is pediatric, 2 is small, 3 is medium, and if you can put 4, is typically large. So that's typically, and once you get the hang of that, it's a lot easier. There are questions about using it with different kinds of procedures. Yes, we have quite a few clinicians who use this for pediatric, for restorative. They've used it across the board. We've got oral and maxillofacial surgeons. It is phenomenal for sedation. And the reason it is because when you look at the fact that it has a bite block and you can evacuate through that bite block, either conscious sedation or IV sedation, it keeps the mouth open, and because it's continually evacuating, you can kind of tilt it back over to the bite block side, and you're able to basically eliminate the fluids that may or may not be pooling inside the mouth. Another question in there was about nitrous. We know, I know personally and seen quite a bit, this is the power vacuum base that Michelle was talking about that's connected to the actual Isolite 3. There's a secondary port down here that clinicians have used to connect to scavenging. There have been actually several papers out there showing how effective it is for scavenging. Not only that, you actually use less nitrous because the patient is breathing through their nose and their mouth, and with the hood in there, it works really, really nicely. So there's quite a bit of information about that. The final thing that I'd like to touch on is that with regard to the aspects of change that Michelle was talking about, I want to be upfront honest. The purpose of this is to inform those of you who are here so that you can make a conscious decision when you're looking at the other devices. One of the things is, because of the way it's structured and put inside the mouth, it does make you kind of have to adjust slightly. And I just want to echo that point with Michelle, because initially she's like, yeah, I'm running into a couple things. We do offer, and it's very important for us. Dr. Hirsch is our inventor. He's a dentist. Education for your hygienists, for your dental assistants, for the doctors who are in the practice. Anytime you need it, give us a call. We'll take you through it. So it's that type of stuff. So I hope we're providing you with the information here that's meaningful. Originally I wanted to present to you 482 PowerPoint slides, and Michelle basically said, if you do that, I'm going to take an ice pick to your head. And I said, all right, fine. We won't do the 452 PowerPoint. So I hope this was helpful for you. I know there are tons of questions. We are in more than half of the dental schools right now. And what we're so excited about is the fact that that ISOVAC can be placed on and moved around in the different ops. And because the dental schools have such a huge variability in how they're doing it, it's working very, very well for them. And finally, when you look the military, the fact that clinicians can work by themselves and they're the only ones inside the mouth, and the mouth stays open. I mean, Michelle resonates, open, open, open. I mean, how often, especially hygienists who are trying to get as much work done, there's this fear around the whole context of aerosol generating and ultrasonics. She uses them, right, Michelle? And
Yeah.
she with again other things. Maybe you've got another upgraded HVAC, you got filters next to you. But the thing is this: use what makes sense and works for you. The last thing we'd like to do is just say, hey, this is the best thing in sliced bread, and there are no silver bullets out there, but there's a really large body of information. I wish we had more time, but it's that. So I don't know, Michelle, anything to add?
No, I would say actually some people were putting comments in there. I was just kind of reading through those. Like, one of the suggestion was safety suction. I've used that too. Pre-COVID, I'm not using aerosol devices at the moment. And I will be very frank, this is my nightmare. I was moving away from even putting a scaler to the tooth ever. Like, that was my real goal. I was doing biofilm management and using more of my ultrasonics. So this is, oh man, rough. But what I will say is that you might not be doing the airflow like I am. So maybe you'll find some suction devices that work a little bit better for you or you have different tips that don't spray as much. So you'll find things that work for you. I'm constantly in that world of like, I'm having something ricochet back at me in my face and the patient. And so I really have to be, mindful of that. And also my technique when using high volume evacuations. I would also say, a lot of things that I read out on social media forums and people that ask me questions, a lot of that is around the tips. And we have to really have a bigger conversation around the vacuums and making sure that your units will even work for multiple HVEs going in every operatory. I think that's a much bigger conversation for us to have, because I could have the whole shebang and none of them will work if I don't have a vacuum that works for me, or works if there are two operatories going at the same time. So I would just encourage you to think at the root of the problem first, and then think about your tips and your ops and your clinicians and what's working for them. And I would just like to echo what I said earlier. Just, understand that we're all going to have to adapt. We're all going to have to adjust, especially if this is something new to you and you're a veteran out there that's been doing this for a really long time. Just show each other some grace, show yourself some grace, have an open mind. Practice makes perfect. But I wish you all the best of luck out there. I'm excited we're having this conversation. It is about time we talk about aerosols and our engineering controls and how important those are. And I am so happy to be included in this panel with you today. So thank you so much.
Cool. Hey, everybody. Thank you for the time. We're out of it. We are in the virtual exhibit hall. Please take the time to go there. We have a lot of information on www.zyris.com. So if you have, please go into there and you'll see that in the support videos, all sorts of things. And then, the things we're learning during a program we call Dental Voice about our clinicians is what we're feeding into that. So Michelle, thank you so much. OSAP, thank you, Chris. Folks, this has been a pleasure. I hope this was helpful. I hope this is information that was useful for you. I'm so thankful and grateful that, Michelle, that you could join us. And at least we didn't do 4,000 PowerPoint slides.
Yes. Well done with that. Thank you.
Cool. Thank you all. Appreciate it. Have a wonderful, safe, and successful rest of the program. This is awesome. Thanks for this.